Welcome, everyone. I hope you can all hear me nice and clear. Let me just check that. Can anyone, somebody just type and let me know you are hearing my voice coming through? All good, great. So welcome, everybody. As you all know, we're doing these webinars as part of an initiative to try and raise some charity 3D print COVID-19.com in an attempt to try and get all the emergency PPE equipment to the front line, and in the process try and develop something that we can be using in our surgeries so we can expedite the opening of dental surgeries again. So you're more than welcome to watch the webinar and enjoy it as much as you can. Hopefully it'll be something that'll be useful to all of you. But if you want to donate, of course that's going to help, but don't feel obliged to donate. It's obviously there as a charity thing. And I hope you all sit and enjoy this lecture. I've pre-recorded it and I'm going to run it as a recording so that I'm able to answer any of your questions that you have. So please feel free to type if you have any questions, and I'll be happy to just interact with all of you and just engage and answer all the questions. Okay, so we'll let's get the ball rolling with that. Welcome to another IDDA fundraiser webinar. Hello everyone, I'm Chris Lefkaditis. This webinar will cover the digital implant workflow, and I wanted to share with you all how the digital workflow has changed the way we practice from the traditional analog workflow to a much more predictable digital workflow. So for those of you that don't know me, I'm Chris Lefkaditis. I'm a digital dentist with a special interest in aesthetic and implant dentistry. I graduated in 1995 from the University of Pretoria, and I am the clinical director of Helston Dental Care in Norwich and a co-director of the Digital Smile Studio on 128 Harley Street in London. I also hold a position as an assistant professor at the College of Medicine and Dentistry in Birmingham, UK, in the Digital Dental Department. And I'm the course director and co-founder of Digital Dental Academy, and a co-founder and vice president of the International Digital Dental Academy. For those of you that have not heard of the International Digital Dental Academy, please visit our website on idda.org. There's a lot of information there about digital dental education, options for membership, and a huge amount of material of videos and workflows to help you on your digital journey when you actually choose to become a digital dentist, or when you've incorporated some form of digital dentistry in your dental practice. So we find ourselves in a current digital revolution. What does going digital actually mean? It means there's a need to adapt to a changing world. Now we know, as part of the fourth industrial revolution, which is really the digital age, we're going to be facing new technologies such as artificial intelligence, automated vehicles, a lot of robotic changes, and automated 3D printing. We need to adapt to that. We need to bring that to our patients. But of course, in order for us to adapt digital, there must be certain advantages. What does this mean? It means that we should have improved efficiency, and we mean efficiency in time and in costs. We need improved accuracy. In other words, it's got to be a lot better than what we had with an analog option. It must give us a high level of predictability, and most importantly for me, it must improve the patient experience, and as the patient journey needs to be better than what it is in an analog workflow. When we compare a scale of advantages and disadvantages and try and assess which one of between digital and analog is going to tip the scale in favor of the other, the common factor we have to consider, regardless of what technique we're using, is planning. And planning allows us to have a predictable pathway to follow to provide us with what we intend to provide for a patient from the beginning, when we actually see the patient for the first time. So planning is obviously crucial, but what we will see is that the planning can really be a lot more efficient using the digital rather than the analog. When we consider an analog surgical workflow, we really have to start at treatment planning. And treatment planning involves getting a diagnostic wax up by the laboratory of the proposed prosthetic envelope of where the teeth need to be in proper function and to give us an aesthetic result. From the diagnostic wax up provided by the lab, they would normally prepare an acrylic process surgical stent, which really acts as a guide for placing the implants roughly within the prosthetic envelope to give us the desired outcome that we've planned from the beginning. But when we look at the stages involved for doing this type of treatment for patients, we normally have an initial consultation where we discuss treatment options, we discuss what the prosthetic options are, and usually we can take an impression at the first appointment, but sometimes we need to leave the patient to decide on the treatment options before we get them back and commence our implant treatment planning. Once we've taken the impressions, these need to go off to the laboratory, and there's an associated laboratory cost. We then need a second appointment to consent our patient and to demonstrate what the treatment plan proposed would be for our specific treatment case. When we consider the analog surgical workflow itself, we usually have to verify the position of the implant placements using verification pins and 2D X-rays to ensure we're in the intended positions as planned. This would usually involve a larger flap surgery because we have to investigate the bony defects and undercuts, and as a result, more extensive sutures with increased discomfort for the patient and a longer healing period. When we consider the analog prosthetic workflow, usually it involves impressions, either with a polyether rubber or vinyl polysiloxane. And we all know that when we do take these impressions, we sometimes have issues with undercuts. There's nothing worse than having to retake an implant impression in a difficult undercut situation. We have the appointment of the abutment selection. Traditionally, we used to use preformed titanium abutments. So the placements, also the angulations, had to be critical for these to be effective. Otherwise, we had to use angled abutments. There's a lab stage involved. After the impressions of having the lab crowns made, these lab crowns then return to us within a few weeks, and then we check, fit, and adjust the crowns. What happens in larger cases? Sometimes there can be a casting error, or there might be a necessity to do a metal tine, especially in the free end saddle, where the articulation becomes a little bit more difficult, and it adds another stage into the workflow, which again extends the analog prosthetic workflow. However, even with the analog workflow, a surgical guide is necessary to help us guide the implants to the correct prosthetic envelope for the technician to give us a desired outcome. How could we next improve accuracy following on from the traditional acrylic surgical guide? The next stage in the evolution of improving surgical accuracy was really the analog guide with a titanium guide sleeve. Now, this was the next stage of development, where stainless steel guide sleeves or pre-manufactured titanium sleeves like these made by Straumann back in 2007 really helped to place the implant in a good prosthetic envelope and the best position for the technician to give us a most predictable outcome. We can see in this case here where the technician has provided the treatment planning with the guide sleeves and having pre-selected standard abutments, that a very accurate prosthetic result can be achieved. Again, the big concern here is there's no correlation to the underlying bone, and we're really working within a prosthetic envelope with no cross-reference to what's happening with the anatomy below the gingiva. Despite that, what we can see is a very predictable outcome based on good articulated planning, where we can see that the technician has carefully planned the outcome and achieved it according to the treatment plan and according to the placements he requested. Around 2004-2005, we saw dentistry achieving new heights in predictability for implant surgery. In 2004-2005, the first guided surgery presented itself into the market. Mainstream dentistry, programs like Nobel Guide from Nobel Biocare and Simplant from Materialize provided a much more accurate surgical guide placement for implant surgery. The problem was it involved multiple analog steps. There was a stage of outsourced radiographic guide fabrication as well, with multiple surgical guides required for placing the implant, and a double scan protocol with a CT scanner, as well as a very high expense. Let's have a look at an example. So here we can see the radiographic guide that's been prepared. We can see that analog steps are involved with this, taking an impression, using a lab to make a diagnostic wax up, and then converting that into a stent with markers in order to be able to correlate the two images and bring the information together for the guided placements. The outsourced surgical guide here, we can see that this has been a stereolithographic guide that's been outsourced to Nobel Biocare, and also very expensive, which we'll look at in a minute. And finally, the stages of making up a lab-made temporary or temporaries, which again had to be outsourced for the treatment to be completed. Now, when we looked at the cost of these, it was roughly £250 bill for the lab bill for the radiographic guide. A medical grade CT scan at the time was an average of £500 for a CT scan. And then we had the lab made crowns and the SLA guide, which had to be paid for as well, really increasing the cost to a substantial amount, almost equivalent to the cost of an implant workflow that we have today from start to finish. So back in 2006, Whitman did a review on accuracy in computer-aided implant surgery. And at the time, it was recognized that the sophisticated technology required substantial financial investment and effort, but it was recognized that it appeared superior on account of its potential to eliminate possible manual placement errors. okay, and to provide predictable and reproducible treatment successes. However, the main point we take away from this is that he summarizes that the potential for the protection of critical anatomic structures and the aesthetic and functional advantages of prosthodontic-driven implant positioning must also be considered, despite the costs at the time. Fast forward to 2013, and we see that Ramasamy and his co-workers concluded that conventionally made surgical guides are unpredictable, and even if implants are well placed, they don't normally meet the optimal prosthodontic requirements. However, higher accuracy is achieved by computer tomography, 3D implant planning software, image-guided template production techniques, and computer-aided surgery. So we can see the evolutionary process is pushing us towards the digital route to try and provide a better outcome for our patients. And what we can conclude from this is that there is an effective evolution to predictability and harmony. Yes, surgical stents work, but we can see with the evolution of how they have evolved, the predictability and the harmony is much improved with the digital technique. As we move along the evolutionary timeline, this paper from 2015, which is a narrative review by Veckerson and his co-workers, concluded that the digital technologies further improve the accuracy, and as this evolves, there'll be a reduction in the number of steps which allow a better execution of the guided surgery, and the final conclusion being that the latter will become easier with the implementation of optical scans and 3D printing. Fast forward to 2020, and we see a bigger need than ever to consider digital workflows in all disciplines of dentistry. What do we need to consider a full digital implant treatment workflow? 4 components are required. The first is a digital intraoral scanner. Second is a cone beam CT. The third is a software which uses the two files from the intraoral scanner and the cone beam to help us and assist us in the implant treatment planning. And finally, the production, which is either cam milling or 3D printing. At IDS last year, there was a massive release of new intraoral scanners. Now, it doesn't really matter what intraoral scanner you use. The important thing is to use it correctly so that you can achieve a good CAD model and an accurate one with the correct scanning technique. And as long as your intraoral scanner can export an STL, you can use whichever scanner you have. When we look at intraoral scanners in dentistry and a review of the current literature in 2017, we'll see that the conclusion here, current intraoral scanners are sufficiently accurate for capturing impressions for fabricating a whole series of prosthetic restorations, and can be integrated in implant dentistry for guided surgery and in orthodontics for fabricating aligners and custom-made devices. So the accuracy is there. When we look at the systematic review by Moreira and his co-workers, looking at the accuracy comparison of implant impression techniques, the purpose of this study was to identify the most accurate impression technique and the factors affecting the impression accuracy, and their conclusions were that the most accurate results were achieved in 2 configurations, but highlighting the fact that the optical intraoral system was very accurate. From a clinical perspective, one of the major advantages of the intraoral scanner is the helping out with patients that really suffer with gagging. One of the nice advantages when you've taken a scan, which is equivalent to an impression, you can selectively repeat an area where you might have made a mistake on the scan. It's not necessary to rescan the whole patient, whereas with an impression, you would really have to retake the whole impression if you have drags, or whether you have the impression pulling away from the tray, for example, or where you might feel that your impression might be inaccurate. The selective repeatability of the intraoral scanner is a major bonus. Let's have a look at an example of selective repeatability or selective capture of an area. So in this case, the patient's been scanned, the original model has been used, part of it has been cut out and then rescanned using the scan bodies. So it wouldn't be necessary to rescan the whole mouth again. You would use your original STL that you had even from the treatment planning phase, which you can then do a cutout and then add the new bits that have been added or the bits that have changed since the original scan. And this is a big bonus for patients because it avoids, in an analog workflow, you would have had to take the original impression for the diagnostic setup, and then you'd have to take a full impression again once you have the your impression copings in. So you'd need a couple of full impressions for the patient, whereas in this case, all we're doing is using the original scan, cutting out the bits that have changed and just rescanning that component. So let's look at a case to discuss the benefits of digital prosthetic planning and how this is so much better than the analog option. So here we have a case that presented, a lady that presented with a fractured bridge extending from the upper right 3 to the upper right 7. What we see is damaged porcelain on the bridge. And when we look at the x-rays, we actually see a fractured root. But one of the things we do know from the 2D x-ray is that we will most likely need a sinus graft or a sinus lift in this specific case. What we can't see is the third dimension, which shows the horizontal component of the bone and what we would be faced with surgically, and how we would be able to perhaps consider avoiding an undercut or a big buccal deficiency, for example, angulating the implant differently. We would have to raise a big flap. So when we look at the increased or zoomed image of the tooth, we can very blatantly see two roots with fracture extending through the crown of the tooth, which has resulted in the failure of the bridge. So the patient gets scanned, the bridge gets removed, and on the second image here, we can actually superimpose the first image so we can see an outline of the existing bridge, which will also help us determine the position of the teeth that need to be replaced. And then finally, we're able to do the diagnostic wax up and show the patient what we're aiming to achieve and how many teeth we're going to be placing in there, the sizes of the teeth, what we're trying to actually get to help us plan the 3D position of the implants. Now, what's great about this? This patient came in, bridge was loose, bridge was removed, she was scanned, she's been shown the diagnostic wax up. There's no lab session where we have to send it to the lab for diagnostic wax up. And then from this data, I've jumped a little bit ahead of myself. Really, what I want to say with this slide is that we still have to respect the knowledge that we have of implant dentistry, regardless of what technique we're using. You know, understanding that implants need to be a certain distance from the teeth and a certain distance from each other to respect the biology, and that has to be taken into consideration both in the digital and analog work. But from that digital scan, we've taken a CT scan as well. We've merged the two data sets, and what we see in the top left-hand side here is how the prosthetic envelope is considered for the placement of these implants. Okay, it also helps us to predetermine and assess the degree of sinus grafting we're going to require and whether or not the fractured root is going to pose a problem if we're going to do immediate placements. So we can see that definitely we're going to need a sinus. On the second implant again, partially require sinus graft. When we get to the third one, we can actually see, instead of trying to follow the bone which sits between the two roots, we have to follow the palatal root in here to try and avoid the buccal perforation, which would happen if we had to follow the buccal root as a guide for placing the implant in an analog method. But the important thing is, you'll see on the blue outlines that the prosthetic envelope is really well respected for where these implants should be. So we know that if we want to get screw retained teeth here, and we want to place them in the center of the teeth, those are the angulations we need. From that, we produce our surgical guide, and we go ahead with planning the surgery. Okay, so what we see here, we can still do the measurements, respect the distances as we said from the earlier slide, and plan where the implants need to be, and then proceed with the implant placements. And we can see the predictability of the placements when we actually do an overlay of the left side planned, the right side carried out treatment, and then the merge of the two softwares or the images so we can see the accuracy of the placements. And then using a digital technique again, scanning these teeth and preparing, which will then restore the patient very predictably with minimal intervention and obviously maximum patient experience for the patient. We saw in that earlier image the selective repeatability. Remember, we would have had these scans from the original treatment planning. In this case, we've just placed our scan bodies or scan flags, scanned the patient, produced the digital restorations without an impression, and finished off the restoration for the patient with a minimal disruption to the patient, no gagging. A lot nicer to have the impression done with a digital technique and a very predictable outcome. The second component, the CBCT scanners, again, a huge array of equipment out there, depending on which company that you have a relationship with and where you've invested. But really, all of these serve to give us a DICOM file, which can be used with any software for treatment planning your implants. Finally, the production phase, which is the milling phase. Again, we can see how fast technology evolves. 2-3 years ago, we were really milling surgical guides. Printing was in its infancy as far as the in-surgery options go. Of course, they could still be outsourced into central facility, but for chairside, if you had the option of a 5-axis or even a 4-axis mill, you'd be able to mill a guide. Here we can see a mill guide that's been prepared, ready for placement of implants and planned in the software. Traditionally, this is how we used to make our guides. We used to mill the guides and then insert the metal sleeve in afterwards for putting the using as a surgical guide for placement of the implants. But more modern way of working now, chairside, is to use 3D printing. 3D printing is a lot more affordable. It's open. It's a very open system because all it needs is an STL file to be nested in its software to be able to print it. And of course, there are some processing issues with completing the work. Not really issues, but additional steps involved with completing the surgical guide. But it gives us the ability to do everything in-house and to do everything in full control of each stage to give us the predictable outcome. When we look at this paper, how accurate are implant surgical guides produced with desktop SLA printers? And in this study, they used a 3Shape Implant Studio software with a Form 2 3D printer. This is 2017, and again, it's been a massive evolution of the printers as well, and really affordable printers from £250. You can get a printer chairside, which will give you the correct accuracy or adequate accuracy for most dental models and aligners and surgical guides. But the conclusion here is that in-office fabricated stereolithographic implant surgical guides demonstrate a similar accuracy to lab or manufacturer prepared guides. So it gives us a convenient and cost-effective means of assuring proper implant placement. With regards to software, again, a huge variety of softwares out there. All these softwares are able to take an STL from an intraoral scanner and a DICOM from a CBCT to merge into a program which has a library of implants for you to be able to virtually plan your implants and design a surgical guide. Now, one of the things with the softwares were that they were very expensive to start off with, but we've now reached the stage where a lot of the softwares like Dentique Guide or Blue Sky Bio, you can actually get the software for free and then just pay per export, roughly around $20–25 or pounds, so that you can get the STL to print chairside. So it really has become an affordable option for every single general practitioner practicing dental implants. Finally, what happens when we have an immediate case? This is an example of the upper left 6, just to show you that virtual extractions can be carried out without worrying about having to take a second impression after the extraction is done. You can virtually remove this, very much like chopping a tooth off the model, but with more control. So in Mesh Mixer, we can see here, we've highlighted the tooth gets extracted, and we've got the STL onto which we can make a surgical guide to place, for example, an upper left 4 and upper left 6 and plan a 3-unit bridge. Following on from the virtual extractions, we then plan the new teeth and the position on the upper left 4 to 6 and upper right 4 to 6, as well as in this case with an anterior open bite. We start to prepare the diagnostic wax up for the anterior teeth to try and create a full arch restoration for this patient. Once we've done the virtual wax ups, the virtual extractions and the wax up, we can then use the model to import into the planning software, design the implant positions, and here we see the implant positions with the teeth overlaid over the top of it, where we propose to put the new arch, fixed arch that we're going to provide the patient with, extending from the upper left 6 to the upper right 6. Now, what about the analog prosthetic workflow for bone level implants? We all know that bone level implants, the emergence profile is always critical to achieve the best aesthetic outcome. But when we look at the steps involved in doing this, we can see that the stages involved is to really try and create that emergence profile we want by making a temporary crown, usually an open tray impression. The lab makes up the crown as the way that they think they should do it. We then add various composite stages to try and push the tissue to where we want to. And then finally, we have to make a customized impression coping to try and capture that emergence profile to communicate it to the laboratory in order to make a screw retained restoration that fits in perfectly with the harmony of the soft tissue. But surely the digital prosthetic workflow must have advantages over the analog workflow. Let's take a look. The emergence of the scan body and scan post, or scan flags, has revolutionized the way we deliver restorations, implant restorations, to our patients. By the use of digital equipment, the intraoral scanner and a milling unit, we can now digitize the workflow to enable us to create a customized emergence profile for whichever situation we're presented with using a tie base. So CAD ceramics have been around for a while. There's various types of ceramics which differ in their composition and used for various applications. And these again have evolved as needs have evolved and as technology has moved forward. But basically with the 3 types of ceramics, which are glass-based, aluminum-based, and zirconium-based, we're able to now chairside produce all these restorations, even in implant dentistry. And from the established workflow that we have with these ceramic materials, the development of the implant blocks has come along, which now allows us to complete implant restorations chairside in one appointment. Ladies and gentlemen, the full digital implant treatment workflow is now a reality and mainstream dentistry. Ladies and gentlemen, in summary, prosthetically driven guided surgery allows for predictable implant treatment workflow. We can see surgical guide here based on the 3D prosthetic envelope planning on the CT scan and being able to achieve a predictable outcome with a very small flap, minimal intervention, and maximum accuracy. With regards to the digital emergence profile, this is captured digitally from reality into the virtual world. Very similarly, the scan body, scan post, or scan flag of various softwares again takes the reality of the position of the implant into the virtual CAD world to enable us to design the prosthetic restoration. Now we move in the opposite direction, where we've designed it in the software and brought it back into reality for the patient. And finally, from the virtual world to reality to give a predictable restoration chairside as planned. When we look at Christoph Hammerly and his co-workers, the summary and consensus statements from the fourth EAO consensus in 2015, the final conclusion here is that the accuracy obtained when following guided implant surgery protocols increases the possibility to deliver an ideal final reconstruction. Of course, there's various methods that we use for creating these crowns chairside. It's a conversation for a different day, but the reality is we're able to produce very aesthetic and very predictable restorations for our patients using and utilizing all the digital tools that we have available to us today to make the journey for the patient a pleasure. I'd like to finish this presentation with the great words of Aristotle. We are what we repeatedly do. Excellence, then, is not an act, but a habit. Thank you very much for listening and joining me tonight. I hope you found this webinar an inspiration if you haven't adopted digital technologies in your practice, or if you have, I hope you found it useful in utilizing those digital technologies to improve the whole experience for your patients and to make your work as a dentist a greater pleasure. Thank you. Thank you, everybody, for joining us. If you have any questions, please just post them at the bottom there. I'll be happy to answer those. And I trust that you guys have taken away a little bit of inspiration, yeah, or hopefully, if you're already using digital, as I said, I hope you're going to go away and just do more with it and get the maximum investment out of your investment that you've made. Thank you. Welcome.